lumbar what? Flexion. The opposite. If we're going sacral extension, we're going to do lumbar flexion. So in that example, some options are prayer stretch. Prayer stretch is commonly called, what is it, was it child's pose? Yoga pose?
Yeah.
I don't do yoga, so, but you know what I'm saying, kind of hands and knees. So we used to call it prayer stretch. I think now, more commonly, people probably call it the child's pose. So you understand what I'm saying with that? Or like a double knee to chest. Again, initially, we like to stay out of unilateral stretching, right? So again, as a treatment strategy, I told you, what I'm going to do initially, this is our strategy, you might have a different strategy, or CI might have a different strategy. My initial strategy is to get it neutral. So I'm really going to not send them home with a lot of exercises. They're going to do that muscle energy technique, they're going to do a couple of stabilization exercises, but everything wants to be symmetrical, right? I don't want them sitting like this. Why? Because this one's going posterior, this one's going anterior type of thing. We don't want that happening. So we want a lot of symmetry. So that's why I don't want to do single knee to chest initially, I'm doing double knee to chest. Keep that symmetry. The opposite is if we want sacral flexion. Another term for sacral flexion is nutation, right? And if we're wanting nutation or sacral flexion, we can't say, generally I can't say I'm going to flex my sacrum. Instead I have to use my lumbar spine. And what spinal motion is that? Lumbar extension, so that's prone line, prone press ups, that 4 point where you kind of tilt in like that with the anterior tilt. Any of those would kind of work, all right? I did kind of give you a sacral rotation option here. Again, the ideal you would be sideline, it says top leg at 90 degrees, and then basically, if I'm like this, then you're kind of reaching back. So it's kind of a rotation stretch. So if I'm laying on my side, then I just reach back. So anything that would rotate is going to be potential. So if you're rotating your lumbar spine, theoretically you're rotating your sacrum as well. You're just kind of transmitting the rotation of your lumbar spine down into your sacrum. If we had a posteriorly rotated ilium, so it's like this, right? What would we want to do to correct that? So here's the, now don't let this confuse you. So if we're posteriorly rotated and we're looking to stretch it, right? How would we want to put it anterior? How would we put it in a Thomas stretch position? We would let it go into extension. So that would be the leg hanging off the table but anteriorly rotated, right? So don't let that confuse you. If we want to posteriorly rotate, what do? We bring it knee to the chest. So when would you want to posteriorly rotate? If it were anteriorly rotated, right? So if you had an anteriorly rotated ilium, if your diagnosis is, I have a right anterior ilium, I would want to do, possibly, after we're stable, a single knee to chest to encourage posterior rotation of that side. Is that clear? So it's kind of confusing.
Why?
It's like the same words saying different things.
Wait. I'm a little confused.
So if you have a anteriorly rotated hip, and you wanted to so what would the answer be? What would you want to do in that case?
If it's anteriorly rotated, you want to posteriorly rotate it, so you would do a single knee to chest?
Correct.
Okay.
That rotates it back.
Okay.
All right? Correct. All right? Rotated ilium externally, right? Again, if you want to rotate, so this is kind of how this is written, interesting. If I want to rotate it externally, I do this type of position, right? So, but that's if I had so the diagnosis there would be an anterior ilium. So in my mind, I say, okay, I want to externally rotate the ilium. How do I go about doing that? I put them in a figure 4 type of position, right? So just don't get caught up on how it's written. That's not the cure. That's what it does. Figure 4 externally rotates. So if you had the diagnosis of internally rotate, or you would want to externally rotate. Everyone clear on that? I understand how that's confusing. I don't know if there's another way to say it though.
For the externally rotated, when it says prone 4 position.
Prone figure 4.
Oh, so you're laying down when you do it? Okay.
You could do a favor. You don't have to be prone. Prone figure 4 is a hard position to get into, especially if you have an SI. You could just do a favor or figure 4 position. All right? So rotated internally ilium, again, this is what they're saying here is you can just get in this kind of position, and if I'm on this side, if I just do that, that internally rotates this side, all right? So that's the position. So if I had an externally rotated ilium, I would want to get in that position and internally rotate it, okay? Superior or inferior slide, again, if we're looking for this type of motion, that's one of those where we use the quadratus, right? The quadratus lumborum, right? What's its action? It does this. So if I had a downslip, again, we said that's very rare, but if I had a downslip on the right, I could lift up on that side, or I could possibly, if I had an upslip over here, I could maybe stretch or go down, I'm maybe stretching the quadratus lumborum on that. So we're kind of, usually with upslip and downslip, we're kind of thinking quadratus lumborum activation or stretch. Now, let's assume that we get this thing all organized back into some normal position. And again, that's basically the first thing. So when I do this, the first thing I do when they come in the next time, I say, hop up on the table. Let's, ask them how it feels, but then I see how we're lined up, all right? If they come in and they're lined up, and if they've been lined up for, 10 days, then we start thinking TheraX, dynamic stabilization. See last week's lecture for that, right? Then it basically becomes core strengthening, right? A lot of these muscles are the same. So then we're doing bridging, we're doing transverse abdominis activation. Again, hopefully we start bilateral movements if possible, right? And then work to unilateral motions. But it really is SI is treated at that point the same as lumbar stabilization, right? There's not really any difference. Pretty clear there? So we know 3 out of 5 special tests to be considered an SI problem. We know the special tests. We know the biggest one it seems like we're going to have to treat in here, that could be practical worthy, would be this anterior or posterior tilt. So you need to be able to assess, is it anterior, is it posterior, what muscle energy technique do I correct it, what stretching exercise would help or assist it, all right? That's the game plan.